Welcome to Beyond the Bottom Line. Today, Paul and I will be speaking with Dr. Lee Goldman, who's professor and dean of the faculties of health sciences and medicine and chief executive of Columbia University Medical Center. Among other things, Dr. Goldman is responsible for in excess of $2.5 billion worth of donations, grants to Columbia. How do you do that?
So the $2.5 billion is just philanthropy. That's not including
pure philanthropy.
Well, not including federal grants.
Okay.
Yeah, so it includes grants from foundations, but that's not the majority of it. People want to give to a place that represents their values and that will be here for the long run. So we represent medical education, medical discovery, outstanding medical care, and we just recently celebrated our 250th anniversary. It was interesting during the Great Recession when philanthropy really declined, sometimes very dramatically for many institutions. Ours went down, but only by a little bit. I think the reason was that people knew that we'd be here forever, and it was not about a temporary uptick or downturn. An investment made at Columbia will be here for at least another 250 years.
They're going to get sick no matter what.
And they'll get sick no matter what.
I can think of no other institution other than universities, maybe the Catholic Church, that's been around that long that gets these kinds of donations. It's interesting. Tell me what a dean does all day long. What's your life like?
I can put it into two categories. One, back to the $2.5 billion. The medical center, medical school, School of Public Health, College of Dentistry, School of Nursing, are now almost $2.5 billion a year in terms of our annual revenue. So part of what I'm doing is managing a very large enterprise. Actually, on a financial basis, more than half of the university. And that's not uncommon. Universities that have medical schools, even if they don't own a hospital, which we don't, typically the medical school, the medical practice, all the grants represent more than half of the revenue of the university. So that's part of what I do. The second part of what I do, though, is different because we're not about pleasing shareholders. We're not about how much money we make. I often say that if we run a chronic deficit, I get fired, but the eminence of the medical center does not depend on how much money we make. It depends on what we do. So my real job, if you will, is to create an environment that aggregates talent, that good people want to join. Faculty should be coming much more than they're leaving, and we bring in faculty at a rate of about 8 or 9% a year. They leave to go other places at a rate of about 3 to 4% a year because presumably either it's a good place to work, or as I sometimes say, at least on the other side of the fence, the grass must be browner. And we also bring in great students. So creating that environment to which top people want to come is, in many ways, the key to my position. So balancing the budget is a prerequisite, but in and of itself, not really the goal at all. It's a means to an end to be a place that great people want to come to.
You recently received a $250 million gift from Roy Vagelos, the former CEO of Merck, $150 million of which is to avoid students who graduate from the medical school having debt overhanging them. How did that happen, and what is the importance of that as you see it?
Sure. So a couple of things. From the time I came here, one of my goals was to try to find a way that we could address the issue of student debt in medicine. And just as a background, many students graduate from undergraduate schools with debt, even in nonprofit institutions. But in graduate schools, people can accumulate substantial debt. Most medical schools, certainly in our peer group, initially had financial aid packages that required students first to borrow at least $25,000 to $30,000 a year before a scholarship would kick in. So my goal was to try to find a way that we could eliminate that kind of student debt, averaging $120,000 to sometimes more than $200,000. Roy Vagelos and Diana shared our 250th anniversary, if you will.
Right.
And from the beginning, we identified eliminating student debt as our top priority. And their $150 million was actually matched by more than $25 million additional dollars, where Roy and Diana said that if someone gave a gift of a certain amount, the scholarship could be in the other person's name, but their gift could be used to match it. So with that money, plus what we already had, we were able to eliminate what we call need-based loans. So if we calculate a student's financial need, $1 and all the subsequent dollars are covered by scholarship. That's different than eliminating tuition, because we also came with the basic principle that if a family could afford it, then they should pay. And if a family can't afford it, then we should be able to provide their child with the kind of education that their capabilities indicate they deserve.
When a student graduates from medical school with $150,000 debt, what is, before your gift, what does that do to the student's choice of careers?
The literature is not what I'll call crystal clear, but certainly there's evidence a substantial portion of students change their career pathways because of this enormous debt. And people have to understand that if you graduate from law school with debt, then you go and work for a Wall Street firm, you can pay it back pretty quickly. If you graduate from medical school with debt, well, you've got a minimum of 3 to 5 years of residency, followed by several years of fellowship. So figure an average of 5 to 7 years, during which you make a very modest wage. So people have 5 to 7 years where they can't pay it back, the interest accumulates, and whatever they had at graduation, after 7 years of compound interest, is substantially larger. And then they can finally get a job. So if you would look at this as an economic investment, medical school is not a great economic investment. People don't go to medical school these days to be the richest person on the block or have the biggest house in town. You go into medicine rather than other professions or fields for which these people are more than smart enough to qualify, because you want to be a doctor. And this allows people to do that.
Do you have expectations that the career choices will change, and if they do, in what way? I mean, because one of the issues that we face in the country is there doesn't seem to be a dispersion throughout the country of the highest qualified doctors.
Sure. So we don't have any requirement. We'll certainly track it, but it'll be 7 or 8 or 9 years after medical school. So this is a decade from now, we'll get the early returns on how this has worked. But I do expect that A, will be attracting a different kind of student to begin with, and B, their career choices will be more broad. That includes practicing in areas either geographic or remunerative that are different than they otherwise would have, but also includes the ability to pursue a career in research, for example, where you discover new knowledge, but are paid a lot less than you'd be paid if you were in private practice. The geographic issue is more complicated. And if one looks back to when I was graduating from medical school, medical students were overwhelmingly men, and they dispersed somewhat more than they do now. Now medical students are half men, half women, and they are commonly paired up with someone else who has equivalent professional aspirations, either in medicine or outside of medicine. The likelihood that those two people can find suitable professional careers in rural areas is not that great. I don't have a quick solution for that. We can talk more about rural health later on, but that's an ongoing challenge as we look at two career issues as opposed to one person looking for an opportunity.
Yeah, because another thing that we've talked about amongst ourselves is the issue of where do you go for a complicated procedure. The smaller hospitals are trying to do catheter valve replacements, but they do maybe 15 a year, whereas you may do a couple of hundred or maybe 1,000 a year. So how do you
We developed it, yes.
How do you deal with that?
So clearly some people's care will be limited by the geographic realities, and I'll come back to that in a moment. But I would say that if you're in a suburban or metropolitan area, on average, you will do better at a place that has higher volumes, and you'll do better at a place that has a quality control system, which places like Columbia have. Here, all the doctors work for the university. We have standards, we have expectations. We have a very large group practice, but it's not like anybody can join. And so that gives some degree of protection. What we've been seeing around the country is an interesting phenomenon, which is that once someone in the family gets sent from that community or suburban hospital into the major academic center where they can do something that the other hospital can't do, and they get saved as a result, the next time someone in that family gets sick, they want to skip right over the community hospital and come right to us. For some things, that's not required. May not even be beneficial for some things, but for many things it is. If you look at outcomes generally, places like our hospital with our doctors have outstanding outcomes.
Well, I always had a rule when something had to be done with me. I want somebody who's done it 500 times.
Well, yeah, there used to be an old joke in medicine that medical training was see one, do one, teach one. That clearly is not where we should be.
Can I go back to the Vagelos gift for just one moment?
Sure.
Roy Vagelos was a man of impeccable reputation. At Merck, Regeneron, his career is just star-studded. What about gifts that might come to the university from more questionable sources? How do you determine when or when you will not take a gift because the source is questionable?
Sure. Well, first I'll say we don't take gifts from just anybody. We look at how their wealth developed. It's unusual for us to decline a gift for that reason, but by no means unheard of. But I can assure you we've turned down sometimes very substantial gifts because of what I would call the reputational issues. A university, a medical school, we live and breathe on our reputation. And if we don't have that, we don't really have anything.
Turn a moment to the issue in terms of the practice of medicine and how things work. Universal health care, big issue in this election. How do you see that, or different forms of it, impacting the quality of care that doctors are able to give and patients are able to receive?
My short answer is it's complicated.
We know that.
Yeah, right. Back in the 60s, organized medicine was against Medicare. Now it thinks it's the best thing since sliced bread. The Affordable Care Act was widely supported by hospital organizations and most doctors' organizations. And repeal, similarly opposed. Repeal and replace, I can't comment until I see what replace might be, but so far we've seen no replace. Medicare for all has a certain appeal, sort of as a public relations message, if you will, and it's basically a way of saying, should we have a universal health coverage paid for by the government? I'm actually in favor of that. Whether that's exactly Medicare for all or not, I don't know. But I also think that the U.S. will always have an additional option. So I see Medicare or Medicare for all as hopefully safe coach class care. And I believe that a country like the U.S. has a responsibility to its citizens to assure them of safe coach class care. I also believe that the U.S. Expects and is okay with the concept of having a business class or first class option, where the wait may be shorter for things where the wait doesn't really matter in terms of your ultimate outcome, but you're willing to pay more to board the plane first. You're willing to pay more to have a private room. You'd be willing to pay more to have a particular doctor do the procedure. I think that option should be available to people, but I think not having safe coach class care for everyone is a moral shortcoming of this country. So depends on what you mean by Medicare for all. If Medicare for all means I've got some basic coverage the government provides, and I can supplement that by adding on to it, I'm actually in favor of that. And I think that would not be a bad idea for Medicare as it exists currently. Some doctors, especially in higher cost areas of the country, would like not to take Medicare because in reality, if they only saw Medicare patients, they couldn't make ends meet. Hospitals have trouble if they only see Medicare patients making ends meet. But if you think about it, Medicare pays everybody the same. There are modest geographic differences. But we like saying, we'll pay every lawyer the same. We'll pay every accountant the same. Every suit, every pair of shoes will cost the same. That's not how we think of the world. We think of, well, my shoes shouldn't fall apart, but if I want them to be fancier, I'm willing to pay more.
Just looking at the shoes here, I'm not so sure.
Well, not my shoes. But there should be that sort of option. So I'm actually in favor of the concept of safe coach class for everybody and some kind of premium that people who want to could pay to have certain amenities. That's fine. That does not mean that if you're having an acute heart attack, some people get treated and some people don't. If I'm waiting for a knee replacement, maybe if I'm willing to pay more, I get the knee replacement a bit quicker, and it takes somewhat longer to get through the queue if I'm on the safe coach class care. And I did want to say back, we were talking about rural issues. In an era when hospitals couldn't do that much, it didn't really matter so much where you were hospitalized. And we didn't see negative impacts of being in rural areas. Now there are acute cares for things like heart attack and stroke that need to be done quickly. And you need to have certain facilities that require specialized equipment and doctors who can be there. And the more rurally dispersed you are, the less likely it is you're close enough to a hospital to get there in time. And even if you did, that they see enough patients to be able to do that. So for example, if you have a heart attack in New York, you'll get what's called primary percutaneous coronary intervention. Someone will go in with a catheter, open up the artery, put in a stent, and that's the best possible treatment with the best possible outcomes. When I was in training, we didn't have that. Intermediate is to give you what's called a clot-busting drug, which is an intravenous injection of a medication that will usually, but not always, dissolve the clot. That's substantially better than nothing, but not nearly as good as the catheter and the stent. If I'm in a rural area without a catheterization laboratory, without a cardiologist, the best I can get, if I get there in time, is the clot-busting drug. So even under the best of circumstances, I'm not going to get the treatment that's 25% better than the clot-busting drug.
So even if you have universal care for all, you're not evening out the treatment between rural and metropolitan areas.
It will help some, because we do also see in the rural areas poverty. So in many of those areas, Medicare for all would be better than what they don't have now. But that alone will not even out the rural-urban disparities.
Of course, the disparity is compensated somewhat by the fact that you can't get through the New York City traffic, so getting to the hospital might be.
Certainly in urban areas, there is some issue in terms of just the traffic piece. But as I said, if you get here within 60 to 90 minutes, any place in New York, you will, it takes ambulances, you're going to get the best possible procedure. The clot-busting drug is 25% better than nothing. The stent is yet 25% better than that. So if I'm in a rural area and can't get to a hospital within 90 minutes, I don't even get the clot-busting drug. If I get there within 90 minutes, I can get the clot-busting drug, but I don't get the stent. So those sorts of disparities are now getting, I would say, built into the system we have. It's not because anyone is malevolent, it's just a simple issue of access.
Lee, is there any system around the world, healthcare system, that you admire, that you think would be an improvement over ours?
In terms of care for everybody?
Yeah, general level of care.
The Canadian system is, is better. in that regard. The British system is fine. Most countries have a two-tier, which means government insurance for everybody, and then private for those who can afford it. In some of those places, the government insurance for everybody is at a level it's not up to our general level, but in Canada and Britain it certainly is. Those countries, though, have different political backgrounds, different political heritages. Certainly in Britain, the National Health Service, despite all of its potential shortcomings, is one of the things that people feel the most proud of and are the least likely to want to change. Canada's is a little bit more free enterprise oriented. Americans often say, well, the people in Canada come to the US to get their knee replacement. Well, yes, the waits are longer there for things that are purely elective. But in terms of the outcomes, they match or exceed ours.
So the criticism I hear from friends of mine in other countries is that your system may be better for the upper tier, the people that are in New York or Cleveland or I don't know, the other.
I'm not going to comment on Cleveland.
No, okay. But for the average person, the coach class, as you describe them, the system in our country is better. Is that a fair criticism?
Depends on the country. I would say if you talk about Canada or Britain, and you are talking about the average working class person, yes. If you're talking about people in the upper middle class in the US, we've got a great system. We also have a lot more vulnerable populations, some other countries do, more diversity. That's great in many ways, but it's not just rural urban, it's also urban underserved. So we have higher, for example, infant mortality rates in these other countries. I was just in France, and life expectancy in France is about 3 years longer than the US. I don't think that's because their healthcare system is better, but life expectancy in France is 3 years or so longer than the US. There are other aspects to health and well-being that go beyond medical care, and we tend not to do as well in those.
Do you think that having a supplemental system, which is criticized as only being available, supplemental insurance for the rich, does it enable doctors here not only to serve wealthier people, but to develop new mechanisms for health delivery?
I'm not sure it has to be a supplemental system, but here in the US, the reimbursement for doctors and hospitals is higher if you have private insurance than if you have Medicare, than if you have Medicaid. The system really can't work in most places unless there's some fraction of people who have private insurance that pays somewhat more. And that somewhat more in part allows hospitals and doctors to care for Medicaid patients, and in part allows hospitals to reinvest and practices like ours to innovate. If you don't have people in aggregate paying what it costs, then the whole system collapses. If people in aggregate aren't paying somewhat more than it costs, then you can't invest in the future.
It's been my observation that medicine attracted the best and the brightest during my whole history. Under a different kind of a system, such as Great Britain or Canada, France, would we continue to attract the best and the brightest?
Well, I can't predict that precisely. I would say that we are still attracting truly extraordinary people. The people who come to medical schools could do anything they want. Medical school is the only profession I know of where fewer than half of the applicants actually get in. People go abroad sometimes to get their medical education because they want to be doctors so badly and they're not spots at American medical schools. The students are truly extraordinary. They want to do something meaningful with their lives. They've decided that maximizing income is not their goal. I say only half jokingly that medicine is somewhere now in between the other professions and the clergy. You don't become a clergy person because you're trying to maximize your income. You don't become a doctor because you're trying to maximize your income. Doctors do make more than the clergy on average, but it's still that sort of compromise people are making, if you will.
And you've seen no diminution in the quality of the people you're seeing.
If anything, they're getting better. But I think in a world right now where people see cynicism, fake news, medicine is like real facts. You're trying to save a life.
Lee, thanks. This has been an extraordinarily wonderful conversation. Thank our viewers for tuning in, and I hope you'll tune in as we continue our conversation with Lee Goldman and discuss some of the issues relating to the pharmaceutical industry in our next episode. Thank you very much.
Thank you.